Hi everyone. So in this video we will understand basic ECG interpretation. So we all have faced cardiac patients in our practice, and they would usually come with their ECG report. And when we see that report, most of the time we are clueless what to tell this patient, whether to refer him or not. So having a basic understanding of ECG is important. It not only help us understand the severity of the situation, but at the same time it develops patients confidence on us. So I won't be discussing the technical aspects of it, how each wave is generated, and all that mechanics, but rather I would be limiting my discussion to the interpretation of an ECG. So what all observation can we make from an ECG? So we can check the rhythm of heart, we can check the heart rate, the axis of heart, or any sort of abnormalities with waves. So now each of these would indicate a certain type of pathology with the heart. We will see each of them in detail in the coming section. So before we start with the interpretation, let's see what does an ECG paper would consist. So typically an ECG paper would have this graph and certain readings. So these readings are electrical activity of which are recorded by certain leads. So these leads are placed at various locations on your body. So you can take a screenshot where all we place the ECG leads. And each of these leads would correspond to certain readings. For example, we have 1, 2 and 3, AVR, AVL, AVF and V1 to V6. Now let's see what all these leads are and what all they record. So basically we have 12 leads. So we have 3 limb leads, 3 augmented leads, 3 chest leads. So this limb lead and the augmented lead that would record the electrical activity in vertical plane, whereas V1 to V6 they will record the electrical activity in transverse or horizontal plane. Alright, so let's come to ECG paper. So a typical ECG paper would consist of square, and inside each large square you would have some small square. So in each large square you will have 5 small square in the x-axis and 5 small square in the y-axis. So let's first see the small square. So the width of the small square, it measures the time, which is 40 milliseconds. So in each small square there would be 40 milliseconds of time, and the height of these squares that represent the current. So each small square would indicate 0.1 millivolt of current. Now let's come to big square. So this big square, it is 5 times the small square. So the values would be 5 times the small square. So over here the height would indicate 0.5 millivolt of current. The width would indicate 200 millisecond of current. So let's start with reading ECG. The first one we would see is rhythm. So when we talk about rhythm, for rhythm we see this rhythm strip. So you will see this two number leads. We have 1, 2 and 3. Then again you have V1. Then again this second time you have this second number lead, and this is the rhythm strip. So with the rhythm strip we will calculate the rhythm and the heart rate. Alright, so before you make any observation, just see if the ECG is calibrated or not. So this is the calibration marker, and typically it should be 1 millivolt. So when it is 1 millivolt, that means it would contain 2 large squares or 20 small squares. So if that contains 20 small square and that corresponds to 1 millivolt, that means your ECG is correct and calibrated. You can make the observation. But if it is not there, then you have to ask the patient to get the ECG done again. So rhythm, what you have to do is measurement is done from the rhythm strip. Check the RR interval. So now I'm assuming we all know what these waves mean. For those who don't know, you can alright, I'll mark it up over here only. So this is the P wave, this is the Q wave, this is the R wave, this is the S wave, and this is the T wave. Alright, so if we want to calculate the rhythm, we see this interval between these two R strip. So if it is equal throughout the ECG, then we say that the rhythm is regular sinus rhythm. So what all the findings in regular rhythm? You will have equal RR interval, and there would be a P wave before every QRS complex. See, we have P wave before every QRS complex, and the distance between two R wave is similar. So it is 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Alright. So how do we observe this irregular sinus rhythm? So irregular sinus rhythm can be of two types. First one is regularly irregular or irregularly irregular. So in regularly irregular, there would be unequal RR interval, but this inequality would be repeated. Suppose you have two large boxes between two R wave, and then you have 5 boxes between two R wave, and that pattern is being repeated throughout the ECG, then that means it is regularly irregular. And in this particular ECG, there would be P wave present. Example is second degree heart block. In case of irregular heart rhythm, there would be unequal RR interval, and it would be random type. There won't be any fixed pattern, and there won't be any identifiable P wave. You can see this particular ECG. It is irregular throughout. There are no patterns, and there is no P wave before the QRS complex. So how do we measure the rate? To measure the rate, there are two criteria. First, if the rhythm is regular. So there is a different formula if the rhythm is regular, and a different formula when rhythm is irregular. So let's see the regular one first. So for regular rhythm, heart rate is calculated by 300 divided by total number of big square, or 1500 divided by total number of small square. We'll see an example over here. So over here we see we have how many large boxes, 1 2 3, and these two combined would be one square. So how much it is in total? 4 total large square. So what would be the calculation? 300 divided by 4, that comes to 75 beats per minute. If we calculate the small box, 5 10 15, 1 2 3 4 5, that means it is 20. So 1500 divided by 20, that comes to 75 beats per minute. Clear? Rhythm and heart rate is clear. Now we move to interpretation. So if the number of big square is less than equal to 3, then that means the heart rate is more than or equal to 100 beats per minute. That means it is sinus tachycardia. If the number of big square is more than 5, more than equal to 5, then that means the heart rate is 60 or below. That means the heart is in bradycardia. Okay, now see the calculation for irregular rhythm. So the calculation is number of R waves in 6 seconds into 10, or number of R waves in 30 big squares. So we all know that one large square, it corresponds to 200 milliseconds. So 5 such boxes would be 1 second, and for 6 seconds we would need 30 such big squares. So let's see an example over here. Here we have a rhythm strip where I have marked from 1 to 30, and let's see the number of R waves between these 30 boxes. So we have 1 2 3 4 5 6. So the calculation would be 6 into 10, that is 60 beats per minute. So now let's see how to calculate the axis of heart. So the normal axis of heart is minus 30 to 110 degrees. It is calculated by lead 1 and AVF. So for rhythm and rate we use the rhythm strip, but for axis we use lead 1 and AVF. So this is your normal axis, this is left axis deviation, this is extreme axis deviation, and this is right axis deviation. So calculation is done using this formula. For lead 1 we use height of R wave minus depth of S wave. For AVF also we use the same formula, height of R wave minus depth of S wave. So for this we would use a table for interpretation. So in lead 1, if R minus S is positive and in AVF also it is positive, the result is normal heart axis. But if R minus S is negative in both the leads, that means it is extreme axis deviation. If R minus S is positive in lead 1 and negative in AVF, then that means it is left axis deviation. If R minus S is negative in lead 1 and positive in AVF, then it is right axis deviation. So now let's see what does these axis deviation indicate. So if we have left axis deviation, that means the left side of the heart is enlarged. If we have right axis deviation, that means the right side of the heart is enlarged. If we have extreme axis deviation, we have ventricular tachycardia. So now let's see each wave. So although I should have discussed it before only, but that would have made the topic little bit boring. So let's start with each waves and what they indicate. So P wave, it indicates atrial depolarization. The duration is 2.5 to 3 small squares, that means 120 milliseconds. The height, it is usually less than 2.5 millimeter in limb lead, and it is less than 1.5 millimeter in chest lead. So here there's something to understand, that in all lead the P wave is always upright, but in AVR lead the P wave is in downward position. In V1 the P wave shows biphasic pattern. Not always, but at times it can show biphasic pattern. So the abnormalities: P wave duration more than 3 small square, that means left atrium enlargement. P wave smaller in height, that means if it is less than 2.5 small square, that means right atrium enlargement. So now let's see the PR interval. It starts with starting of P wave to starting of R wave. Normally it would be 2 to 5 small square, that would correspond to 120 to 200 milliseconds. These are the abnormalities associated with short PR or prolonged PR. Q wave, it is due to ventricular septal depolarization. The waves are considered pathological if it is more than 2 millimeter deep or it is more than 1 millimeter wide. So pathological Q wave indicates current or prior myocardial infarction. So this Q wave, it becomes extremely important. Now let's come to QRS complex. So QRS complex, it is formed due to ventricular depolarization. So the normal duration would be 2 to 2.5 small square, that corresponds to 80 to 100 milliseconds. So now let's see the abnormalities. So if the QRS complex is narrow, that means there is supraventricular tachycardia, atrial fibrillation or atrial flutter. If it is wide, that means there is ventricular tachycardia or torsades de pointis. So now let's come to the ST segment. So it begins from the end of S wave to the beginning of T wave. So as seen in the diagram, so this is the ST segment. So here there is something that I want to discuss is J point. So J point marks the beginning of ST segment. So in different ECG, this J point would be at different position and at times it gets confusing. So I will just show one diagram over here. So we'll identify where is the J point. So this is your P wave, this is QRS, and over here this is your ECG. So P wave, this is Q, this is R, this is S, and this is T. So over here where is our J point? So J point over here would be the end of S wave. So this is our J point, and from here only we will calculate the elevation. So how much it is elevated. So now our ST segment could either be elevated or it could be depressed. So the elevation, if the elevation is convex, that means it is myocardial infarction. If it is pericarditis, it would be concave, and in hyperkalemia also we see ST elevation. So ST depression is seen in hypokalemia and chronic stable angina. So the lead of ST segment elevation can tell us about the location of myocardial infarction. So if it is present in 2, 3 or AVF, it would be inferior wall. If it is present in 1, AVL, V5, V6, lateral wall. If it is present in AVR, V1 and V2, it would be septal wall. If it is present in V3, V4, it would be anterior wall. Now let's come to the T wave. So T wave is due to ventricular repolarization. So the height of T wave would be less than 5 millimeter in the limb lead and less than 10 millimeter in the chest lead. So abnormalities: Hyperacute T wave is seen in myocardial infarction. Tall tented T wave, it is seen in hyperkalemia. T wave inversion, it is seen in hypokalemia and myocardial infarction. Okay, so in case of hyperacute T wave, the R wave would be bigger than the T wave. In case of tall tented T wave, the R wave would be smaller than T wave. Okay, so now let's come to QT interval. So it start with Q wave up to ending of T wave. It indicates ventricular depolarization plus ventricular repolarization, and normally it would be 9 to 11 square. That means 360 to 400 milliseconds. And QT interval is inversely proportional to calcium. So if we have prolonged QT, then the serum calcium is low. If we have narrow QT, then serum calcium is high. So these are the conditions when your serum calcium would be high. Alright, so this is a diagrammatic representation of the normal sinus rhythm and the associated and certain abnormalities. So that's all for ECG. So if you have any queries or if there's any place I went wrong, you can correct me in the comment section. Thank you.